The carbapenems are another group of antibiotics, with the prototypic drug being imipenem. And these antibiotics are active against most bacterial pathogens, including organisms that are resistant to other antibiotics, but none are active against MRSA. Okay, so while it's a pretty useful category of antibiotics, it's not active against MRSA. So it's highly active against gram-positive cocci and most gram-negative cocci and gram-negative bacilli. Okay? It's the most effective beta-lactam antibiotic for the use against anaerobic bacteria. Okay? Anaerobic bacteria are bacteria that can live in oxygen-poor environments. Okay? And an example of an oxygen-poor environment is the interior of your GI tract. Okay? So you can see how different antibiotics are going to be helpful for different infections throughout the body. Because different organisms prefer different parts of your body. Okay. So carbapenem is the larger class category, and imipenem is the prototypic drug of the carbapenems. Okay, and it's really the only drug we're going to talk about. But understand that when you see the suffix penem, they are part of that carbapenem group. Okay? Now, vancomycin. Vancomycin is another cell wall inhibitor. Okay? Vancomycin is an incredibly useful and powerful antibiotic. Okay? It is frequently a last resort antibiotic when you're faced with resistant infections. Okay? It inhibits cell wall synthesis. It does not contain a beta-lactam ring. Okay? And it's really used against very severe infections. It really shouldn't be a first-line antibiotic. It is very effective against MRSA. Okay? It's also effective against C. diff. Okay? There is a enterobacteria that is resistant against vancomycin. Okay? It's called VRE, vancomycin-resistant enterobacteria. Okay? And that's a very troubling, that's very, very difficult to deal with because vancomycin is one of our go-to drugs. Okay? And the big fear among providers and infectious disease practitioners is that we will start to see more and more vancomycin resistance. Okay? And since vancomycin is one of our ceiling drugs, and drug companies are not really motivated to produce new antibiotics, right? Because they know resistance is inevitable, and antibiotics are generally very cheap. And so dollar-wise, there's just no motivation to develop new antibiotics. So when we see more and more vancomycin resistance, we're going to be in a real difficult place. I'm sorry, what's that? Someone with VRE, there are other drugs that we can choose that are a little more active against these anaerobic bacteria that we see. Yeah, there are thankfully other drugs for VRE, but when we see if we start to see more vancomycin resistance in other types of infections, there isn't going to be anywhere we can go. Intravenous administration is necessary for vancomycin. It really has very poor GI absorption. Okay? So it is a drug that we're frequently giving in hospital intravenously. Okay. Now, vancomycin, very, very useful drug, but it also carries with it some adverse effects. And these stronger antibiotics, as we'll find, do have far more toxicity than the penicillins and the cephalosporins. Okay. Vancomycin carries with it ototoxicity. Okay, so it can damage the inner ear and lead to hearing loss. And that hearing loss can be either reversible or permanent. Okay? And it's frequently a dose-dependent difference, or how long the person's been on vancomycin, or whether vancomycin is being combined with other ototoxic drugs. Okay? And I'll tell you, in terms of information that the NCLEX loves, just like the NCLEX loves myasthenia gravis, the NCLEX loves ototoxicity. I don't know why. And ringing of the ears is a phrase you will hear frequently. And I think it's obviously because it's very important, right? But there's lots of drugs that are ototoxic, and you should know what they are. Okay? Vancomycin, another drug that we'll talk about, gentamicin, furosemide, remember those, the loop diuretics, right? Those ototoxic drugs, if a drug is ototoxic, just like put a little label in your head. And if you ever read a question where ringing of the ears is particularly if it's a priority question, like what are you going to be the most concerned? If you hear ringing of the ears, that's going to be a big deal. Yes, ma'am. No. And so I've had several conversations between last week and this week about this idea. So for our purposes, right, there's always differences between drugs. Okay, there's always differences between drugs. The question is, at our level here, with this first introduction to drugs, what differences are most important, right? And so for our purposes, if you can basically draw a circle and put a class of drug, right, and just assume that they are exactly the same in terms of adverse effects and therapeutic indications, right? Unless I specifically mention something different, all right? If I don't mention anything different, you can treat them the same. That's right. And that's not because they are exactly the same in every single way. It's just they're similar enough in terms of how we are consuming them right now. Okay? Yeah. Okay. Red man syndrome is another one that red man syndrome and malignant hyperthermia is another adverse effect that the NCLEX loves. Ototoxicity, the NCLEX is very sadistic. Ototoxicity, red man syndrome, and malignant hyperthermia, those are things that they love. And so red man syndrome is a syndrome where it's fairly racist in just its name, but let's put that aside for a moment. But basically what it describes is this systemic inflammation that happens when people get IV vancomycin sometimes. And so people get this flushing of the skin, right? So basically their skin turns red. They get a rash, they're very itchy, urticaria, those are the hives. They can get tachycardia and hypotension. Okay? So it's really a systemic inflammation. And usually if someone is reacting this way, the vancomycin is just being, first of all, it's only with IV administration. And the vancomycin is probably either dosed too high or the pump rate is too high. Okay. So if the vancomycin dose is too high or flow rate is too high, this red man syndrome is more likely to occur. But some people are more reactive than others. Okay. Thrombophlebitis is also a problem, right? It's an IV drug, and so it can cause thrombophlebitis. Thrombocytopenia refers to decreased platelets. Okay. And so this is relatively rare, but it can happen. Vancomycin can cause platelet production to decline. People do have allergies, right, against vancomycin. People have allergies against all these antibiotics, but vancomycin included. And renal failure as the most sort of life-threatening and not frequently seen, but can occur. Now, we also see drugs that are bacteriostatic inhibitors of protein synthesis. Okay, so they block protein synthesis. They're not weakening the wall like all the other ones that we've mentioned. They block protein synthesis, and what that does is slow down the rate of cell division. Okay, and so it will slow down or decrease this spread of the infection. But they're not bactericidal. They don't kill the bacteria. Okay. There's the tetracyclines, and tetracyclines we'll see again in the treatment of peptic ulcer disease because they're active against H. pylori, which is an important bacteria behind peptic ulcer disease, right? There's also the macrolides, and the macrolide is a larger class, and under the macrolide is a drug called erythromycin, okay, which you'll frequently see, right? When babies are born in this country, we rub their eye, regardless of who their mother is and who they are, unless you specifically ask not for this to happen, we rub their eyes with erythromycin ointment because mothers who are infected with gonorrhea and their babies get infected because of passing through the vaginal canal, gonorrhea-related blindness used to be a really big thing, okay? And still would be a big thing if we didn't do this. But of course, if you're a mother who knows you don't have gonorrhea, you can request that your baby not get erythromycin ointment. What's that? It's a law, you have to do it? So you can't request not? I feel like my kids didn't have that. Oh, some states. Yeah, okay. New York State it is. Really? I'm from New Jersey, and we are more civilized there. No, I'm kidding. I'm totally joking. Don't want to start that war. But I did not know that. I did not know that it was a state law in some places. Okay, I'll keep my mouth shut about that. All right. But erythromycin, you won't forget that drug now, right? Just think of like greasy-eyed babies when you think about erythromycin. So the tetracyclines, again, bacteriostatic, not bactericidal. It's a broad spectrum category of antibiotics. There are 4 members of the tetracycline family, and they are available for systemic therapy, meaning that they're usually taken orally, but they're not topical or anything like that. That's all that means. And there are some pharmacokinetic differences between the different drugs. But there is tetracycline, democlocycline, doxycycline, and minocycline. Really? No. That there's slight pharmacokinetic differences that I'll mention. And the main difference is that you can't take anything with calcium with some of them at the same time because it can delay absorption. And I'm positive that is true of doxycycline, and I think it's also true of minocycline. I'll mention it in a moment. Okay. So the tetracyclines are broad spectrum. They inhibit protein synthesis, and they increase we are starting to see increased bacterial resistance. Okay. It is used to treat infections, obviously, but it's also used in a wide variety of conditions that are associated with chronic infections. Treatment of acne sometimes. If chronic infection has been associated with that acne, tetracyclines might be appropriate treatment. Peptic ulcer disease because of H. pylori, periodontal disease because there's bacteria that are commonly associated with periodontal disease, and rheumatoid arthritis. Okay, and the rheumatoid arthritis, there are complications of rheumatoid arthritis where the arthritis can become infected, right? Infected joints, and so the tetracycline can tackle that part of the treatment. It can also be used on Mycoplasma pneumoniae. It's frequently used to treat Lyme disease. It can be used to treat anthrax and H. pylori, as I mentioned, with peptic ulcer. Okay. Tetracyclines are frequently not used for monotherapy, okay, particularly against active infections. Acute infections, I should say, not active. So chronic infections, tetracyclines can be used alone, okay, the kind of infections like H. pylori. But for acute infections, where the bacterial cell number is really rising rapidly, the tetracyclines are rarely going to be used by themselves. Okay? They're going to be used in combination with some kind of bactericidal drug so that you're killing bacteria and slowing growth. I'm sorry? Okay. Yes, ma'am. Mm-hmm. So the one antibiotic at a time or one antibiotic ever? One antibiotic. So one of the reasons for using combination antibiotic therapy is to avoid resistance, right? And also to enhance efficacy. So with H. pylori, the person's going to be on that antibiotic for quite a long time. And so the main goal with not using a single antibiotic is to try to decrease the likelihood of resistance developing. Okay. So with tetracyclines, they can all be taken orally, okay? But the absorption of the tetracyclines, all of them, are reduced by food. Okay? So we tend to advise people to not take these tetracyclines with food because it will reduce absorption. So we have the issue of chelation with calcium with the tetracyclines. So calcium supplements, milk products, iron supplements, magnesium-containing laxatives, and most antacids, if you take it with the tetracyclines, will decrease absorption. Right? So you shouldn't be taking these tetracyclines with any food, but also watching your calcium intake when you're on it is also going to be important. It's for all tetracyclines, but it's particularly important for doxycycline and minocycline. Okay. What's that? Yes. All of them you shouldn't take it with food because it's going to reduce absorption. Yeah. And so for individuals with peptic ulcer disease, as we'll talk later, people with peptic ulcer disease, if they're on tetracycline, they're probably also taking antacids, right? Because that's part of the treatment. And so that's going to be very important to make sure that they're not taking those antacids anywhere near the time that they're taking the tetracycline. Okay. So adverse effects, GI irritation, right? That's an unfortunate situation since we can't take it with food. That would potentially mitigate that irritation, but it'll also decrease absorption. So GI irritation is definitely going to be an issue. Your GI tract is generally not happy on most antibiotics you will have to take. Nausea, diarrhea are very common experiences on antibiotics, but GI irritation also with the tetracyclines. Effects on bone and teeth. So the discoloration of teeth, and this is particularly a problem with children. Okay? The tetracyclines can darken teeth, can discolor the teeth, the enamel, and for children that can really be a permanent thing because what they're actually doing is changing the color of the teeth while they're still in below the gum line. Okay. Have you ever seen a skeleton of a child with all the teeth, right? So they're born with all those teeth, but they're up here in their sinuses or something. And then as they get older, they come down. And so all of those pre-teeth up there, they get discolored by those tetracyclines. So we don't give these drugs to children. And then with the tetracyclines, particularly because we give them chronically frequently, superinfection is an issue. So a superinfection, right, is not an infection that can fly or with superpower. A superinfection means that you are being treated with for one infection, okay? And then during treatment, you develop a new infection. Okay? It's super as in supra, right? But it's also problematic because this infection has developed in the environment of an antibiotic already being there. So it's kind of opportunistic in a certain way. And anytime you're on an antibiotic, there's a risk for superinfection. Hepatotoxicity, right? It is difficult on the liver, renal toxicity, and photosensitivity. So individuals who are taking tetracyclines should be very careful about using sunscreen when they go out because they're going to be much more sensitive to UV light from the sun. Yes, ma'am. Sorry. Hi. It's not toxic. So it is. So chelation does refer to the binding of calcium to something, right? And so you do produce precipitates. but these precipitates are not toxic. It's just that the precipitates prevent the drug from being absorbed. Yeah, you're welcome. Okay. So major precautions with tetracyclines. Tetracycline, Democlocycline are eliminated primarily in the urine, and they can accumulate in patients with kidney disease. Okay? So with patients with kidney disease, okay, these are one of my emphasizing moments. Patients with kidney disease, we're going to avoid tetracycline and Democlocycline. We're going to, so that means that patients who have poor renal excretion, we're going to prefer to use something like minocycline or doxycycline. Tetracycline and Democlocycline. Okay? All right. So that's one. And another one I mentioned, we want to, tetracyclines can cause discoloration of deciduous and permanent teeth. So that is most relevant to children. So we want to avoid using tetracyclines in children because it will stain their teeth permanently. If someone is on tetracycline and develops a bout of very persistent diarrhea, we want to be concerned because that can represent a superinfection. Most concerningly, it could represent C. diff. And so what do we want to take in whenever we're on any kind of antibiotic? A probiotic, right? If you're on an antibiotic, you can take a probiotic. Now, I went to a conference in May, and I learned for the first time in my 43 years of life the difference between prebiotics and probiotics. Did not know this. You guys are probably, some of you are probably further along on this than me. But a probiotic, right, those little drinks or those pills or any kind of cultured dairy or if you're so inclined, kombucha, right, or any of those fermented or cultured stuff, what they do is they introduce good bacteria into your gut, okay? But that bacteria does not colonize your gut. It doesn't stay there. Probiotics go in you and then come out you. And in order to replace them, you have to literally keep taking that probiotic. Prebiotics are usually forms of fiber that actually, when you consume them, they create a gut environment that makes habitation by good bacteria more likely. Okay? So a prebiotic is, like I said, it's usually a form of fiber, and it can, shockingly, fruits and vegetables are really good sources of prebiotics. So basically, if you just eat well, who would have thunk it? It means that your gut now is very rich in exactly the perfect kind of food that good bacteria thrive on. So if you're eating a combination of prebiotics and probiotics, what you're actually doing is changing your gut environment so that the good bacteria that you're introducing are more likely to thrive and stay, right? And so instead of just going on vacation and then getting the hell out of there, they might want to just like build a little cottage in your colon, right? And set up shop. It's so lovely here. Why don't we live here? All right. So while it is important to have probiotics when you take antibiotics, it's also important to like get some prebiotics in there, just in general as baseline. Yeah. It's a good question. So they probably do, but when you take a probiotic, you're taking like, particularly like a pill, you're taking like billions and billions of bacteria. And so if the antibiotic kills off half of them, right, there's still enough, and you're constantly providing a new source every day to compete off those bad bacteria. Does that make sense? You're welcome. Yes, ma'am. Yeah. It really needs to be taken without food, yeah. So you can't combine it. You can't take tetracyclines with like a calcium-containing antacid. They're like Tums, right? That's chewable. But I'm not sure about taking tetracycline along with like a proton pump inhibitor or an H2 blocker, right? But that isn't going to really help in terms of GI upset. Yeah. Okay. And then, so diarrhea is likely on the tetracyclines, but when diarrhea occurs, particularly if it's intractable, you want to make sure that it isn't a life-threatening superinfection, right? High-dose IV therapy has been associated with severe liver damage. Okay? So we want to be particularly careful about giving IV tetracyclines for people with impaired liver function, okay? Because it can push them into acute liver failure or cause some pretty severe liver damage. Okay. So absorption of tetracyclines, we already mentioned this before, I'm going to say it again. Absorption of tetracyclines is decreased if the drug is given with milk products, calcium supplements, iron supplements, magnesium-containing laxatives, and most antacids. Okay?